Go ahead now.
Dave, I'm just scrolling down to see how we're doing on attendance. I think we should get going.
We still have 2 board members, but I think we can get started. I agree. We're down to 1 board member that we're checking on, but I think you can get started.
Okay, that's kind of what I was hoping for. So this is Sue Birch, and I am calling this meeting to order. So good morning and welcome everybody. A few reminders as usual. Due to COVID-19, the board has previously agreed that we are meeting today via Zoom only. Our opening slide has information about how attendees can turn on closed captioning subtitles. Again, I thank the members of the public that brought this to our attention. And I thank members of the staff for implementing and getting all the appropriate licenses so quickly. I'd like to begin with board member introductions. I'll do the roll call to identify the board members who are with us today. So board members, you can start unmuting yourselves. Harry Bossi.
Yeah, good morning, Sue. Thank you.
Good morning. Elliot Weinstein.
Here.
Hi, Elliot. Thank you. Monica McLemore, are you back from London?
I am present.
Great. We're glad you're back on our shores. Scott Nicholson.
Scott is who we're checking on at the moment.
Okay. Please, staff, let me know as he arrives. I think we are expecting Scott. Tom McRobert, you're next.
I think I'm here.
Thank you, Tom. Leanne Kunze.
Good morning. I am here, and sorry that I have to be off video. My Wi-Fi is just not strong enough to have them both going at the same time.
No worries, Leanne. Thank you so much for joining us. And last, John Comerford.
Here, and I'm in London too.
Great. All right. Also, Michael Tunick from the Attorney General's office. Are you with us today?
I'm here, Director Birch. Thank you.
Great. And as I said earlier, I'm Sue Birch. I am the board chair. Now for a few more reminders. With both board members and presenters attending virtually, it'd be helpful for the board to hold their questions until each presentation is done, or when the presenter pauses and asks if there are questions. Board members will watch in case you use your Zoom's raise your hand feature to indicate you have a question. As usual, manual hand signals work, and or if for some reason we don't get you, do jump in. We know this is so respectful. We don't really consider that interrupting, but our process keeps holding. But I'm just reminding folks that is our process. The public will have an opportunity to provide general comments at the end of the meeting during the public comment period. As a reminder, when a resolution is scheduled for action, I also call for public comments specific to that resolution just before the board takes any final action. And again, members of the public, we strive to be so inclusive, and just please be patient. We will monitor, we have staff monitoring, but we want your input, and we will weave it in throughout the meeting if you're new to this process. All right, Dave Eisminger, I think you are now going to provide us an overview of today's agenda.
Yes, good morning, Chair Birch and members of the board. We have a relatively light but important agenda today as we are culminating on our final meeting of this board season. Tanya will be back, our finance manager, with the non-Medicare premium resolution. And then we will have an additional relatively brief presentation for Ellen's recent stints here at the board, but some additional content that continues to try to work on answering questions that have been raised in the past couple of months in the Medicare space, and continue providing insights and discussion with the board about the Medicare portfolio, and again, trying to answer more and more questions as they continue to come up. And then I will just review a little bit of the details of next season's board schedule for calendar year 2023, and we'll have public comment and be finished for the day, or this morning. And great. I do want to say that our background today is Mount Baker. I'm sitting here thinking whether that's Yes, no, this is Mount Baker, and it's highlighting the majestic eagles as well in the background that are often seen in our state. So that's the background HCA folks have today.
Great. So Dave, I think we'll move into our first agenda item, the vote on approval of the meeting minutes. And today we're going to vote on 3 sets of meeting minutes. And if you'll go to your tab 3, we'll go through this process. The first vote is for July 14th, 2021 meeting minutes. Board members, any comments from you? And if not, do I have a motion to approve the minutes as written?
So move.
Thank you. Is there a second?
Second.
Thank you. Monica, all in favor?
Aye.
Yes,
Aye.
Any opposed? All right, July 14th, 2021 minutes are approved as written. Let's move to the next vote, July 21st, 2021 meeting minutes. Are there comments from the board?
Yes,
Go ahead, Elliot.
I'm not sure typos matter. It's a very tiny typo. It was on page 2, paragraph 4, line 2. Add a C before the care in primary care.
Elliot, thank you for your attention to detail. We strive to be better, so we will take that edit.
Okay.
Are there any other comments from the board? All right, if none, do I have a motion to approve the minutes as written?
motion here,
So
Harry.
moved.
Thank you, Harry. Is there a second?
Second.
Thank you, Leanne. All in favor?
Aye.
Aye,
Aye.
Aye.
Any opposed? All right, the July 21, 2021 minutes are approved as slightly amended with a typo correction. All right, next we'll move to vote on the January 26, 2022 meeting minutes. Are there comments from the board? Elliot, you got any typos in there? Okay, we got those. Connie's smiling. Any other comments from the board?
Chair Birch, can you please say the date again?
January 26, 2022.
Thank you.
Do I have a motion to approve the minutes as written?
Question, Sue?
Yes.
You said, did you say 7/26?
January 26, 2022.
Oh, I'm sorry. Okay, thank you. Thank you.
We're just moving quickly, huh? Okay, are there any other questions? And can I get a motion? Oh,
This
go
is
ahead.
Monica. I just want to confirm, since I was not a member of the board at that time, I probably should abstain from this vote, correct?
That is correct.
Thank you.
Do I have a motion to approve the minutes as written?
So
So
move.
moved.
Thank you, Leanne. Is there a second?
Second.
Thank you. I believe that was Tom. All those in favor?
aye,
Aye.
Aye.
Great. Any opposed? And the January 26, 2022 minutes are approved as written. And we should note that Monica has abstained from the vote. All right, let's move on to our next agenda item. Dave, will you take us into the follow-up from the July 14th, 2022 meeting? Dave is coming back to provide us just any clarification or answer any questions on follow-up items from our last meeting.
Thank you again, Chair Birch. Dave Eisminger for the record. This is one of those interesting ones where the closeness of the meetings at the end of the schedule, we have to be producing materials before we know what's happening. And that's my way of saying there were a lot of variety of different questions and ideas that came up at last Thursday's meeting. It feels like it was much longer than 6 calendar days ago, but it was just 6 calendar days ago. But the vast majority of questions are things that we'll be working on for the retreat. And in particular, there are some questions that were raised about Plan S and Plan G and the enrollment process for F versus G and the differences. And all of that will be worked on for the January retreat as part of our follow-up and continued information about Medicare. We'll also make sure that we're addressing anything that happens with federal legislation between now and then. But I didn't have any, I believe, specific questions that could be addressed so quickly between the most recent board meeting last week and today. Elliot, I see you have a question though.
Yes, thank you for bringing this up. In the past week, I have developed another question. It sounds like I've developed a cold, but it's the same, I guess. What I wonder about is, I was reading Social Security and Medicare bulletins, and they said that, Plan G, I think you pay the deductible for Plan B when you're in Plan G. And the bulletin, and Ellen knows this because I asked her about it. The bulletin says that if you're born before a certain date, you don't have to pay the deductible. And Ellen explained to me that this was a PEB requirement, which is fine. Since unfortunately I wasn't here when this decision was made at the retreat, if you could explain a little bit about why PEB makes this requirement when the federal government doesn't. Sort of the history behind it.
Yep, thanks, Ellie. We'll wrap that into kind of a sub-question I think John asked last meeting about enrollment limitations in F, and so we'll kind of bucket it with that at the same time. Yeah, there's definitely some things that go through related to the supplemental Medigap plans and just kind of reorienting everyone to that and the current state of it. So that's definitely on the to-do list. Just unfortunately, I appreciate that additional question and reinforcement of that. Just unfortunately not a lot of business hours between last Thursday and today.
No, I wasn't expecting anything like that. If you could dig up some what is it, pages from that meeting, that would be great too, just to show us what those folks saw.
Elliot, we will try through our archival records to answer more of those questions. And so thank you for being patient. Any other questions for Dave around follow-up from the July 14th meeting? All right. If not, we're going to move on to our next agenda item. This is the 2023 PEB non-Medicare rates. Tanya Duell, our ERB finance manager, is back today for the board to take action on the non-Medicare rates presented at last week's board meeting. And after Tanya reviews the resolutions for action, I'll read the resolution and then I'll ask for a motion to adopt in a second. Then I will invite public comment on the resolution. And then I'll ask for discussion from the board until we're ready for a vote. Tanya's materials are behind tab 4. Tanya, I'm turning it over to you.
All right, thank you. Good morning, Chair Birch, members of the board. For the record, my name is Tanya Duell. I'm the ERB finance manager, and I am here to ask the board to take action on the employee and non-Medicare retiree premiums for calendar year 2023. Last week, I presented rates, and those premiums are included in your appendix for reference. And as a reminder, before we walk through the resolutions, by the board adopting each of the resolutions, the board is approving the premiums and the underlying plan design for any fully insured carriers for that specific carrier. So they don't go plan by plan, they're carrier by carrier. We have 3 resolutions for the board to take action on today. One for Kaiser Northwest, one for Kaiser Washington, and one for the Uniform Medical Plan. So next slide. This is the first of the 3 resolutions, and I will pass it back to you, Chair Birch, to walk through the resolutions.
Thank you. So again, this vote is for the premium resolution PEB 2022-17, Kaiser Permanente Northwest non-Medicare premium. Resolved that the PEB board endorses the Kaiser Foundation Health Plan of the Northwest employee and non-Medicare retiree premiums. Is there a motion to adopt?
Motion made.
Thank you, Harry. Is there a second?
Second.
Second.
I believe that was either Leanne or Monica, both probably. So thank you. Are there any comments from the audience? Connie and Dave, you'll help me monitor screens. I am not seeing any signals or hearing anything. Are there any comments from the board? All right, this will be a roll call vote. Let's begin. Harry Bossi.
Aye.
Thank you. Elliot Weinstein.
Aye.
Scott Nicholson.
I have not been able to confirm Scott, and so he's absent.
Okay. Monica McLemore.
Aye.
Thank you. Tom McRobert.
Yes.
Leanne Kunze.
Aye.
And this is Sue Birch, and I vote aye as well. Premium resolution PEB 2022-17 passes. All right. Let's move on to our next vote. It's the premium resolution PEB 2022-18. This is Kaiser Permanente WA non-Medicare premium. And it reads, resolved that the PEB board endorses the Kaiser Foundation Health Plan of Washington employee and non-Medicare retiree premiums. Is there a motion to adopt?
So moved.
Thank you, Harry. Is there a second?
Sue, that wasn't me that made the motion, just for the record.
Oh, I'm sorry, maybe Tom?
Yes.
Thank you, Tom. Is there a second?
Second.
Thank you, Monica. At this time, I'd like to see if there are any comments from the audience. I am not seeing any signals. Are there any comments from the board? All right, we'll move on. This will be a roll call vote again. Harry Bossi.
Aye.
Elliot Weinstein.
Aye.
Scott's absent. Monica McLemore.
Aye.
Tom McRobert.
Yes.
Leanne Kunze.
Aye.
And this is Sue Birch, and I vote affirmatively. Premium resolution PEB 2022-18 passes. Now we'll move on to the vote for the premium resolution PEB 2022-19, the UMP non-Medicare premium. Resolved that the PEB board endorses the Uniform Medical Plan, known as UMP, employee and non-Medicare retiree premiums. Is there a motion to adopt?
So moved.
Thank you, Leanne. Is there a second?
Second.
Thank you, Elliot. Again, members of the audience, I'm calling for comments. So are there any comments from the audience? Are there any comments from the board? All right, we're just moving swiftly. This will be the roll call vote again. Harry Bossi.
Aye.
Elliot Weinstein.
Aye.
Monica McLemore.
Aye.
Tom McRobert.
Yes.
Leanne Kunze.
Aye.
And this is Sue Birch voting affirmatively. And premium resolution PEB 2022-19 passes. All right, good job. We got through that for you, Tanya and team. Let's move on to our next agenda item. More Medicare portfolio insights. Again, we're joined by Ellen Wolfhagen. She couldn't be with us today as we had planned. So we've got Jean Bowie, who's equally as capable. She's our Deputy Director of the Employees and Retirees Benefits Division. And she's going to share more info on the Medicare portfolio. Jean's materials are behind.
I want to apologize, Chair Birch. I think I mixed up meetings this week since we have a subboard meeting tomorrow, and I gave you the script for Lou tomorrow instead of Ellen is here today.
Ellen, I see you there. Okay, never mind. We are so glad we have Ellen. Jean, we love you too, but we've got Ellen this morning. So Ellen's materials are behind tab 5. Go ahead, Ellen.
Good morning, Chair Birch, members of the board. Thank you. So today I'm going to concentrate on some information between the United Healthcare Plans and UMP. This is because the bulk of the questions that we received were specifically about United Healthcare Plans and the comparison. Next slide, please. So we're going to go over some comparisons on providers and pharmacies. And then I will talk a little bit about premium and out-of-pocket costs. Next slide, please. You'll note that this is a much faster presentation than usual. So today we're going to talk about the overlap in provider networks and pharmacy networks and the pharmacy transition process between UMP and United Healthcare. Next slide, please. The good news is approximately 97% of current UMP providers are also currently treating United Healthcare patients. I know that we've heard a lot from people concerned about whether their provider is actually under UHC or accepting the UHC plans, and the good news is almost everybody is. About 2% of UMP providers have no claims on file. That doesn't mean that they wouldn't accept UHC. They just have not yet filed a claim with UHC. And less than 0.25% of UMP providers say that they will not treat UHC patients. Or they are providers who are outside the United Hearing Network, which is a required network for hearing aids.
Ellen, before you move on, I want to say about this provider disruption report. I've seen a lot of provider disruption reports in the last 5 years as director, and this is one that has some of the most profound overlap. I was really surprised, and that we've been working on like pressure testing this for a bit because there was such comparableness between the plans. I did want to just note that in my experience with looking at provider overlap and provider disruption reports, that this one did have significantly high overlap. That is, anyone who has seen a provider that doesn't have overlap obviously has a significant impact. So typically when we see provider disruption reports, it is not in the high 90th percentile of overlap. I do think it's also important to highlight one piece that Ellen said last week, just to kind of reinforce something that's unique in this particular space. And that is there are some providers who have not signed a network contract, but they still accept the plan and treat patients and bill United Healthcare even without a network contract. There's no cost share difference to the member by seeing that provider, whether they're in or out of network. But one of the big differences is they don't show up in a provider online directory. And so there's about, I believe in here somewhere around 4 to 5% of the providers are in that scenario where they won't show up in an online provider directory and may appear, and they truly are not, quote, a network provider, but because there's no cost share difference to the member and because they are treating and billing United, they look and feel like a network provider contract. If they're just harder to see in the directory. And that's where we have, I think Ellen's statement was, it's best to directly contact the plan because over the phone, they can confirm more of those situations where a provider is not a network contract provider, but yet still is accepting the plan and billing them. So there's that interesting nuance. I just want to acknowledge that it's around 4 to 5% of the provider population that falls in that non-network yet accepts the plan bucket. Ellen, did I get anything wrong with that?
No, absolutely right, Dave. Thank you for the clarification. Okay, moving on to networks. These are the top chain outlets, and both UMP and UHC also cover small individual retail outlets. But I just wanted to give you a flavor of this. The top outlets are Walgreens, Walmart, Rite Aid, Publix supermarkets, which I don't think we have in the Northwest, Kroger Company, which includes Fred Meyer, and Costco. And you'll notice there's very slight differences between the number of locations between UMP and UHC. UHC has a few more, and those must be individual Walgreens or Rite Aids that actually participate with UHC and are not in UMP. I do want to make a couple of statements. I want to remind folks about the changes for 2023 on the pharmacy benefit for UHC. United Healthcare is moving to copays rather than coinsurance. So the copays for tier 1 is $5, $45, tier 1 is generic. For brand name generics, it's $45, or preferred brand names, $45, $100 for non-preferred brand names, and $100 for specialty drugs. Specialty drugs are limited to a 30-day supply. However, another benefit of UHC in 2023 is the cost for a 90-day supply is actually only 2 times the 30-day supply copay. So that would be $10 for tier 1, $90 for tier 2, $200 for tier 3. Again, because specialty drugs are limited to a 30-day supply, it's still $100 and it would only be a 30-day supply. I have not prepared a slide on the transition for pharmacy because the simple fact is it's a matter of walking into the pharmacy with your prescription and your United Healthcare card, and that's all that's needed. So there really is no transition process. You take your prescription to, let's say, Rite Aid or Costco, and you show your United Healthcare card because that shows who the pharmacy benefit is with, which is Optum, and you can get your prescription filled. I'm going to open it up for questions here before we move on to premium information.
Elliot, I see your hand up. Go ahead.
Yeah, just a simple, quick question. I'm assuming that this slide shows data US-wide. Am I correct? As opposed to just the state of Washington.
That is correct, Elliot. This is nationwide data.
Okay, thank you.
Dave, I'm not seeing any other questions.
Go ahead, Ellen. I'm not seeing any either.
Okay, great. Now, next slide, please. Now I'd like to bring you some information about state pension benefits, because some of the questions that we've received talk about the relationship between the ability to pay premiums and people's fixed pension income. Next slide, please. This slide is about the Public Employee Retirement System, PERS. There are 3 plans in PERS, PERS 1, PERS 2, and PERS 3. PERS 3 has an employer contribution factor, and it also has individual employee factors. These data were supplied by the Department of Retirement Systems. I want to point out that there's the average monthly amount, so that's a strict average, the sum of all the payments divided by the number of payments. And then the median is the actual amount of the midpoint. So there's a slight difference between the median and the average. I also want to point out that not all of these retirees that are listed are in PEB. They can be receiving retirement pension benefits from more than 60% of the PERS 3 people put 5% of their salary in a defined contribution amount. So PERS 3 allows people to choose different amounts that they put into their defined contribution. Next slide.
Ellen, you broke at a key point, so I just want to restate one piece in case it didn't come across. The number of retirees that are listed here under PERS 1, the 37,000, the almost 58,000 under PERS 2, and the 6,700 under PERS 3, that's total state or DRS retirees. That is not synonymous with PEB retiree subscribers. PEB retiree subscribers are mostly a subset of all of the number of DRS retirees, and we do not have an easy or current way to match just to bring you PEB numbers, but we did want to bring you the context of what does a typical state pension look like for various plans and the various three pension systems. And the other part that I think might have been chopped off from Ellen is, we know that there are other retirement benefits outside of PERS, CERS, and TERS that some or many retirees have. And this in no way tries to quantify that. What we wanted to simply do was provide some of the context as to the state pension piece, because there were quite a few pieces of correspondence that highlighted that relationship between the state pension benefit, because many state retirees use auto debit or pension deduct processes, and DRS automatically forwards premiums to the healthcare authority before distributing a pension amount. And so there's often a lot of connection and concerns related to the monthly premium for various plans and the monthly pension that is administered by DRS because of that ease of paying premium using your pension payment. So we're not trying to provide a lowball amount of what the fixed income is of retirees, because obviously there's Social Security that most people have. People may have invested in a 401k, they may have a spouse's retirement benefit. There's a variety of different other potential aspects to what an individual retiree fixed income is. And this we recognize is simply a snapshot or subset, but it does have that relationship to pension deduct and how many people pay their premiums to the healthcare authority. Wanted to provide that context. I think I got everything that might have been chopped off, Ellen.
Thank you, Dave. I apologize for the network quality. It appears that my connection dropped. Okay. I also wanted to point out that if one were paying for UMP Classic Medicare, it would amount to about 20% of the pension benefit just going to that premium, and it could be upwards of 25% of the median amount. So just something to keep in mind. Next slide, please. This is a similar chart relating to TERS. TERS is the Teacher Employee Retirement System, and it's for certificated personnel. So these would be teachers, counselors, principals, etc. And again, the employer-only contribution, just as a reminder, there could be other contributions. Employees can put aside different amounts for their defined contribution amount. And again, even in tiers 1 and tiers 2, the premium for UMP Classic could amount to at least 20% of the pension. Next slide. This is the school employees retirement system. These are non-certificated personnel. This would be groundskeepers, bus drivers, etc. You will note that there is no SERS 1 program like PERS 1 and TERS 1. So there's only SERS 2 and SERS 3. And again, you can see that the median amount is much less, and therefore the impact of premiums would be much greater for this population.
And Ellen, just for folks, so many classified staff are significantly part-time workers, which also then would reflect out in their pension benefits. So if you're wondering why the pension benefits for SERS, the median and average are so different than TERS or PERS, it's the population that is in SERS tends to be heavily part-time.
Next slide, please. So a theme of the questions that we received was I'd have to pay more upfront and less. I'm concerned about paying more upfront and less at the time of the services, or I'd rather pay more upfront in terms of premium and less at the time of services. I wanted to point out that for the majority of standard benefits under the United Healthcare plans, there is no, especially under PEB Complete, there is no fee at the time of service, so you're not paying more at the time of service. And PEB Balance has significantly low copays, so the amount there is also not as big. In comparing UHC and the UMP Classic, basically you pay more with UMP overall. I just want to note that Kaiser plans also have lower premiums, and they also contain protection, as does United Healthcare, for pre-existing conditions. There are no requirements different for retirees with pre-existing conditions. The majority of services in UMP and United Healthcare have the same or higher coverage with United Healthcare Complete. And UHC's premiums, as we have said before, can be lower because of their risk-adjusted federal subsidies that are not available to a plan like UMP Classic Medicare, which cannot take advantage of those federal subsidies. And I've shared a lot of information this past season. There will be more next season as well. We'll keep informing the board, the public, and our PEB members about various aspects of the Medicare portfolio. And with that, I will open it up to questions.
Ellen, as we transition to questions, I just want to highlight one more thing on slide 10. This is really what it, when HCA, when Ellen, when our communications are saying economic value, this is a key part of that economic value, part of the equation of plan selection that we hope to help members better appreciate as we go forward. Because it is natural, as Ellen said, many people think of you pay more in premium and less at point of service, or you pay less in premium and you pay more at the point of service. You kind of add to that knowledge about the general individual market, that if you have a $0 Medicare Advantage plan, then it comes with significantly high out-of-pocket expenses when you do have services, or a high out-of-pocket maximum. And so it's very challenging, I think, to think about how because of the federal subsidies, that logic doesn't pan out for all of the PEB benefits. Just because there is a lower premium doesn't mean that it manifests as higher point of service out-of-pocket costs. And just because it's a higher premium in PEB doesn't mean that it results in a lower out-of-pocket cost for services. And so that's one of the challenges, because it is counterintuitive. And it comes back to that subsidy difference that we've tried to highlight so much in the past couple of years. And last board season to this board season. So that's what Ella was really trying to highlight, that piece of it, because it doesn't follow logic. It absolutely doesn't. And it kind of is counterintuitive to everything we've all learned about insurance and how we interact with insurance. So it's a very important kind of concept for us at HCA to help people better appreciate as go forward.
Another.
Elliot, you have a question? Oh, go ahead, Ellen, and then Elliot.
Sorry, I just wanted to say another savings aspect or comparison aspect is because under the United Healthcare plans, there is no difference in copay between in-network and out-of-network. That also results in savings or higher coverage for some of the benefits.
Elliot, go ahead. Your hand is raised.
Thank you. Dave, this is another thing for the retreat. You folks have brought this up. Could you also cover how at least some of the organizations that I represent and others represent can help you get a subsidy perhaps for other plans? What action can we take to support you in that?
Absolutely, and Elliot, we won't wait to share that with stakeholders who are interested. We're putting together that kind of short synopsis of the U.S. code that would need, that is specific to this aspect, and the Code of Federal Regulations. The USC is the equivalent of RCWs, and the CFR, the Code of Federal Regulations, is the equivalent of WAC. And so we're putting together that kind of crosswalk so that people can be aware as to what specifically are the federal statutes and rules that relate to this concept. I think we have the research done. It's just kind of synthesizing it into a quick package for folks. We'll share it with the board, but we also won't wait until January to share that with interested stakeholders.
But I also think it's important to help us understand what action we can take, because this world is familiar to you. But let's say I'm a retiree golfer. This isn't my world necessarily.
Yep, appreciate that, Elliot. That's a great call.
I would also just like to chime in that later today, the newly appointed, not so new, but the Healthcare Cost Transparency Board is meeting, and these are public meetings, and they are doing a deep dive into hospital costs. And there'll be national and state level data about profitability and just what is going on as we continue to see healthcare costs mushroom in the nation, because we are one of now 7 states that are putting in cost growth benchmarks, really signaling to the industry kind of the game is up for you continuing to price egregiously, and this has to stop. And so we're doing a deeper dive into the complexity of this because those costs bake into premiums. And I think there's a lot of belief of, and there's a lot of misinformation and media campaigns. And I think we would all agree that getting down to the very specific costs of what healthcare truly costs and should cost are a lot of debate and discussion and exposure going on. So please know you are all invited to join us at the Healthcare Cost Transparency Board later today. It is from 2 to 4, and it too is publicly available to learn more about the cost structure that we have to contend with. And I saw another hand up. I think it was Tom.
Yes, thank you. I recognize that some of the things I'm about to say are anecdotal, so therefore there's not really a basis, factual basis. However, having said that, there seem to be a lot of concerns about United Healthcare and how they interact with providers. I know just in the last month, I've talked to 2 people who flat out will not accept United Healthcare, period. and two more who basically won't accept any insurance because of their the lack of payment from the insurance companies themselves. So having said that, and having said that it's anecdotal, I would like to see us undertake a study. And maybe we can do that in conjunction with our partners, such as WA Retired, RPAC, et cetera, to monitor the experience of our subscribers who have United Healthcare. I think it's very important that we have a very firm understanding of, because I believe United Healthcare will be the principal beneficiaries of making switches out of Uniform Medical. I'd like to have a study done that basically quantifies the experience that those people have had in making those switches. And also the fact that we have 4,000 that made that switch already. I'd like to have some type of study done as to what their experiences have been. Have they been positive? Have they been negative? And if so, what are the specifics that they've experienced? I would like to see that done not only between now and our next retreat, but also during the year 2023. Thank you.
Tom, thank you for that suggestion. Elliot, I see your hand up next. And for Mr. Burton, we will be taking public comment later in the public comment period. So we recognize your hand, but we're going to ask you to patiently wait. Okay, great. Elliot?
Tom, this is meant as a friendly question. I think it would be helpful also if the retired organizations got to look at the study and contribute to it, just so that they have some input.
Thank you, Elliot. I believe we are embarking on some very significant listening tours. As many of you know, our budgets are submitted to the legislature after we go through kind of a governor's budget process. So Tom and Elliot, we hear you. We will be looking into that, what that might cost, how we might implement. We do have to get authority to move in that direction. So as we round out our listening sessions, it's something that I think we can bring forward. John, I see your hand raised.
Yes, following up on what Elliot and Tom were mentioning, do we do any kind of client satisfaction survey? And do we identify the companies that people respond to us about?
Yeah, we absolutely do satisfaction surveys. And Dave, you want to report out on what our partners present on a regular basis. And I don't know that it's specific to plan transition, but we do satisfaction surveys regarding their experiences.
And we do that by company, so you know the difference between Kaiser Permanente and United Healthcare.
That is correct. And Regents does surveying as well.
Is that something you can share with the board?
We will be bringing back information about what we have accumulated in the past. There are things called CAP scores and other satisfaction tools that we use. And the problem's going to be, it's probably more focused on their medical care than necessarily the admin business processes. But we will, Dave, I don't know if you have further information or if we need a little time to put that together.
I think it definitely need time to put it together, but I hear the spirit and intent of the question. I think you've done a good job of the 50,000 foot view of kind of what some of the lay of the land. But I see John that wrapped up as kind of related to Tom and Elliot's point. Point taken.
Elliot, your hand is up. Oh, maybe that was an old hand.
Thanks, John. That was a great observation. I would, when you produce these satisfaction surveys, I would like to know who conducted them, because that makes a difference I'm just speaking for RPEC. Thank you.
Great. And we know that some of the satisfaction tools that are used nationally by our different trade associations, they have varying levels of efficacy, but generally we have an intermediary that's doing satisfaction ratings with those tools. But we'll get back to you with a very specific presentation, and we'll blend that in sooner, if not for sure at the retreat. All right. Any further Oh, Ellen, do you want to continue to take us on?
That was my last slide, Chair Birch. Thank you.
Okay.
So there's
Thanks.
no further questions. Thank you so much for your time.
I'm not seeing any further questions. Let's handle the next agenda item, and then Mr. Burton, thank you for waiting patiently. You will be the first in the queue for public comment. Dave, our next agenda item is the 2023 PEB board meeting schedule. Could you please share the information regarding the schedule? And board members, this is behind tab 6 in your packets.
Yes, thank you, Chair Birch. This is just the published regular meeting schedule planned timeline for the PEB board for the 2023 board season. At the end of the board season, we go through the official publication process. There are a variety of different rules under the Open Public Meetings Act related to different meetings, and these are the regularly scheduled meetings, and we set the schedule for the entire board season. You'll notice that in general, it stays with the theme of Thursdays starting at 9 a.m. And then has an end time. We always publish a longer time, and sometimes as this board season, we use the entire time that was published, and other times it ends up being much shorter. And we know as the season goes on a little bit more, as we get closer to meetings, how long we think each of those meetings will run. So the board retreat this year, we're used to doing board retreats in January. I know it was extraordinarily challenging in the last year or two when we had back-to-back days of board retreats. That was very challenging for our HCA staff to have 2 all-day staff meeting or board meetings back-to-back. So we are separating them. So for the first time in a long time, I think we're seeing the word February associated with the board meeting. And it's just kind of the way the calendar falls. So the board retreats at the very beginning of February, and then we generally stick with Thursdays. I do want to highlight that, like this year, we always publish and schedule multiple meetings in July that because we don't exactly know how the timeline is going to work for rate setting. Our hope and intent is to always use 2 of the 3. Very rarely do we use 3 of 3. So I did want to highlight that. And those tend to be shorter meetings. So we've kind of tried to reflect that a little bit in the published time, but they may be even shorter, like today's meeting is turning out to be. So just wanted to highlight those various features. I also wanted to say, we don't know what the world's going to look like 6 months from now. Right now, the board has agreed to continue all virtual meetings. I think it would be challenging to ask the board to take some sort of stance as to what to do in January or February when we don't know what the circumstances are, and kind of the requirements around having virtual only meetings really is kind of a little bit circumstance dependent. But what I can say for the board and the public is, even when we get to a point where we have a physical space for the public, we will continue to support at a minimum hybrid meetings. And so that means that the public and the board members will then always have the choice as to whether you want to attend the physical meeting location here in Olympia, or if you want to continue to attend virtually. That will be totally everyone's choice. We will not go to a world, the world has fundamentally changed. We're not going to go back to pre-2020 when we have audio only, but most people are in a room together. So I did want to reassure folks that regardless of what the world looks like, there's a commitment to having hybrid meetings where there's both virtual access and in-person access, and you'll have absolutely, as board members and public, when we are in a hybrid world, the choice of how you want to participate in meetings. And we can address at the beginning of the board season what the world looks like then, and make a determination if we stay all virtual or whether it proceeds to a hybrid world. But I just want to provide as much reassurance as I could 6 months into the future as to what things can look like next.
Thank you, Dave. And I also want to just note that our schedule every year is filed with the Office of the Code Reviser. And so it was filed July 12th. And it's important to understand that because, again, these meetings are very public. We love the participation and the input, but we also, board members, make certain that this goes further in our governmental process so that others can understand that we are meeting and these are publicly open and we encourage all sorts of inclusion. All right, at this point, I would like to call for public comment. And Mr. Burton, you have been waiting patiently. Connie, I think you're developing the list for me. And Dave, as usual, if you'll help me, I think Mr. Burton, you're first, and Fred, you'll be on deck second. And we have ample time, but we ask people to keep their comments to, 2 to 4 minutes. And please identify yourself before you speak. And yeah, and for others lining up, I see Linnea is third. So Mr. Burton, you'll be first. Go ahead, sir.
Hey, thank you, Madam Chairperson. It's Mike Burton, retired teacher. I had really 2 questions. Under uniform medical, I do not have a gatekeeper. In other words, I do not have to go to my general before I go to a specialist. That's been a very positive thing. Under the other plan, the UHC, do I have to go to my general to get approval before I go to a specialist? The second question is, under UHC, does the insurance give the general a bonus for keeping costs down? I have a sister, unfortunately, that is in her 3rd round of cancer. Her general she has now has basically stiffed her on getting the proper procedures, proper blood tests, and so forth and so on, because they receive a bonus if they keep the costs down. So those are the 2 questions I would like answered. Thank you very much.
Thank you, Mr. Burton. I'll ask staff if we have answers for your first question or if that needs to come back. As to your second question, I think it's important to understand that Washington, as well as our country in general, have embraced a notion of value-based care. And so we offer some performance incentives about things like incenting the right kinds of care and disincenting wasteful care. And when we talk about care, we look at evidence-based science and evidence-based decision-making. So we don't look at this as bonuses. We talk about things like bundled payments, centers of excellence, performance incentives, shared savings. So it's a little hard to comment about what you, without more specifics about what your sister is experiencing. I'm not aware that people get bonuses in that way, but the concept of value-based purchasing and contracting is absolutely embraced and endorsed by this state and our agency. And in our country, there has been this movement towards trying to disincent a lot of fee-for-service or unnecessary, wasteful, possibly dangerous care. And Dave, I don't know if you want to add on or if Dr. Transu wants to comment at all. I'll turn it over to you, Dave.
Yeah, I can start, Mr. Burton. There's always a lot. What I hear at the heart of your question is you want to make sure that there's clear communication about how specialty services are accessed under the United Healthcare Plan, and there's probably a couple of different ways to answer that question, and I recognize that probably what I'll say right now and what others add in may not provide the full picture, but I want to make sure that I'm walking away with this and making sure that among the questions that we're trying to answer for our retirees, we know that this is something that needs to be comprehensively addressed. The piece I'll highlight is that the United Healthcare plans are PPO plans. They're preferred provider organization plans, just like the Uniform Medical Plan. which differs from, say, a health maintenance organization or an HMO setting. The needing to see a primary care physician to get a referral for specialists is something that is more commonly associated with HMO products than with PPO products. So in general, the PPO product environment has fewer referral type requirements. But I want to caution my own statement right there with, we need to be able to add the context of how prior authorizations work, because there are prior authorizations that may be required for specialty services that aren't with the primary care physician, but are with the health plan. So to the extent your question was about needing to see a primary care physician in order to access a specialty service, in general within a PPO product, that's not typically a feature of those product lines. And again, United Healthcare is like UMP in that way. However, there are other potential plan design aspects that could require prior authorization, which feels like a referral almost, to access those specialty services. So I'm going to have my team come back with a more comprehensive type answer and make sure that we incorporate that into our overall communication strategy. Ellen or Dr. Transu, if you're on, is there anything that you'd add to that
Dave,
insight?
this is Ellen. I just want to add, there is no referral required under UHC to see a specialist. And the prior authorization referrals that Dave was just alluding to are the same under UMP or under UHC. So if you needed a prior authorization under UMP, you would need it under UHC. And I also want to say that UHC does not have, our contract does not have a bonus for keeping costs down. So there isn't that kind of incentive to providers, to individual providers.
And this is Dr. Train. So I would just add one piece to that. Many health systems now are having a requirement of a referral before a specialist will see someone that has nothing to do with insurance. So we've been starting to hear some feedback of people of, I just want to go straight to the dermatologist about my rash, and health system X is saying I have to see, be referred by my primary care provider first. And I just want to call out that distinction. We can't control what the individual providers will do. If a dermatologist says, I am so swamped with people, you have to have seen somebody else, make sure that you really need to see me first. That piece isn't under our control with any of these health plans. So I just wanted to call that out as well. I think otherwise everyone spoke about these issues.
I believe, Fred, you are next in the queue. Go ahead, Fred Yancey, if you'll identify yourself, please. And Linnea, you're on deck, and then I believe it was Mary Lindsay. And I guess we'll come back to Fred because I'm not.
Sorry. I'm sorry.
There he is.
It took a while for the unmute button to show. So good morning, Chair Birch and members of the committee. I just wanted to say a couple of things. One is as your season concludes, to thank all you and the members of the board for all the time they put into this process and will continue to put in. And I have appreciated the opportunity to learn some of what all these things mean, and your communication, I believe, has just been outstanding, and I appreciate the work that I believe Connie does to kind of put together the packets and so forth. But again, thank you all for the work, and I appreciate the fact that you put up with my ignorance. Thank you.
Fred, I will convey your gratitude to the entire team. They really do an amazing job, Connie and all of them, and Dave. So we will be certain to highlight that within our internal communications. We really appreciate that recognition. All right, Linnea, I believe you were next, and then Mary, you're on deck.
I'm Linnea Mulder, and I worked as an RN for about 40 years, UWMC. I very much appreciated Tom's suggestion regarding a study, and I asked specifically that it include medical and pharmacy pre-authorization and appeal processes, outcomes, and experience. And Ellen, I appreciate that both Uniform and United have a pre-authorization process, and I think, again, I would appreciate that it be transparently and thoroughly reviewed what the processes are specifically in the appeal process. And thank you very much for the opportunity to participate.
Thank you, Linnea. Mary Lindsay, if you'll open your mic, and I believe you were next in the queue. If you'll identify yourself and make your comments to the board.
Thank you. Mary Lindsay, WA retired president. I have just three brief comments to make. One is that I've heard from two members this very week that Walgreens does not take UMP at all. And so at least the classic Medicare, that people can't get a shot there, they can't get their medication there. So I've heard from two different people. So you might want to check on that. Another thing is that you might want to correct the slide. You have TERS. It's Teachers Retirement System, so it's TRS, and it was on there as TERS, like PERS. I know it gets very confusing for members about that because that's Public Employees Retirement System, so you might want to check that. And the third thing, I'm very excited to hear about the commitment to do a hybrid meeting model next year that really gives accessibility to people throughout the state to come and be a part of it and hear the information and see the slides and all the good things that you are sharing with members. So I really appreciate that. So thank you very much.
Thank you, Mary. We appreciate those comments. I think, Elliot, you're my next person with your hand raised.
Yes, this is in response to Mr. Burton, and this is anecdotal. I've spoken.
Elliot, if you'll identify yourself for the public.
I'm sorry, Elliot Weinstein, speaking as a member of the PEB program. I have spoken to my chiropractor who says that the UMP pre-authorization requirement, it happens more often also with chiro and with massage. The pre-approval processes in UMP are not burdensome and don't take forever, but they are burdensome to chiro, my chiropractor, and my massage therapist, as is the billing process for UHC. And it takes more time. And as a result, my chiropractor will not work with UHC. Thanks.
Thank you, Elliot. And maybe staff can follow up to get specific names so they can follow up. We can certainly flag that for UHP. Connie, Dave, are you seeing any other hands up? And I can't tell if Barbara Fristow, I believe, Barbara, if you'll unmute yourself, I see a manual hand being waved.
Hi, thank you.
If you'll identify yourself.
My name is Barbara Fristow, and I am a previous employee of UWMC as an RN and as a nurse practitioner. And my question, I'm wondering if you have presented or you have data on what the costs have been for UMP and for other of the plans for the care that's been given to justify why there's been the increase in premium. The other thing I'd just like to say that's a comment is I'm very opposed to the privatization of Medicare. And I think that's what the UHC plan is aiming at. It seems like there's a big drive towards the privatization. And I think Medicare has, traditional Medicare has provided excellent care and at lower costs than the privatized plans. So I just want to make that comment too. So thank you very much.
Barbara, thank you for those comments. I do want to clarify, we have had several inquiries about this notion that suddenly Medicare is privatizing. Medicare is a federal program. They made decisions years ago about Part C and subsidization of the large national carriers. So there are federal policies that overlay many of these pieces of things that are playing out. And 2 years ago, we contracted with United Health Plan. So this is, as Barbara, and I don't know if you've been at many of our earlier meetings, but we do not control the federal subsidies that back some of these plans and guarantee kind of their business structure. And we don't endorse one way or the other what people consider the privatization of Medicare. We are simply trying to assure our role as fiscal stewards and make sure that people get the most value for the healthcare dollar they're spending, because we have a duty to really dig into the costs and the quality. And so we appreciate all the comments so that we can kind of dig deeper with all the carriers and plans that are involved. Dave, Connie, go ahead, Dave.
I don't see anyone else signed up. I did want to let Mary Lindsay know we'll follow up about Walgreens and UMP, but Walgreens became in-network as of January 1st, 2022, or at least they're supposed to be. So we'll definitely need to follow up on that. I even remember driving through Lake Stevens earlier this year and seeing the marquee at a Walgreens in Lake Stevens said, "Welcome PEB and SEB UMP," and I was kind of taken aback as I was driving and saw that on a Walgreens marquee. But they are supposed to be in network as of this calendar year, so we'll likely reach out to follow up and see if we can track down exactly where the disconnect is. But Walgreens is supposed to be in network. I don't see any other public comments signs up.
Okay. So we will conclude this part of the public comment, and I'll do one last call in case anybody's having trouble getting off mute. I don't see any hands being signaled or virtual hands going up. So we are concluding public comment. A few announcements before we adjourn. Our next meeting, this is, I'm sorry. I think somebody might need to mute their microphone. Dave, I'm going to test you. Are you getting any feedback? Even though Dave and I are in the same hallway, are you getting any feedback from me, or did I drop off?
We had a brief
okay.
background feedback, but you're coming in loud and clear, and I think we're good to go.
Okay, sorry about that. This is our last meeting of the year. We will meet again in early February for our retreat, as we shared next year's calendar. And Dave, any final comments or anything else we need to cover before we adjourn? I think we have possibly some change in our board composition.
Well, there's two things. I want to highlight one piece as we haven't really finalized or even drafted an agenda for the retreat. It's several months away. But one thing that, there'll be a lot of different pieces that have been brought up in the last week as requests for things to be discussed at the retreat or sometime early in the board season. I do want to say that over the next couple of months, the agency and the staff here pivots to open enrollment. With your adoption of the premiums, we are full steam ahead. And the turnarounds are quite quick. It doesn't feel like it's October yet, but it is October when you start thinking about print production deadlines. And so things move very rapidly here at the Healthcare Authority, which is why the board season traditionally ends at the end of July, if at all possible, whenever possible. So we'll be pivoting to open enrollment. But the other important work that we're going to be doing, not just for the next 5 months, but we'll come back at the retreat to talk about how things are going, is that engagement. I'm calling it kind of an engagement strategy when it comes to our Medicare portfolio, our retirees, and our various stakeholders. And I say engagement because we have a lot of different stakeholders that we need to engage with. It's RPEC, it's WA retiree, it's the School Administrator Association, WSFRA. It's also our higher education institutions. We have large employer groups that have joined us specifically knowing what the retirement benefits are for their individuals. So there's a wide range, and all of those entities have different interests in what those engagements look like. And so I just want to be clear that a lot of people throw out different words. We'll do listening sessions and work with entities that want to have listening sessions. We'll work with entities that want to have webinars, that want us to do more presentation style. We'll do roundtables, whatever the engagement is that type of stakeholder wants, we will work with that stakeholder to have those engagements. And that's why I just wanted to be clear as to why I'm calling it kind of an engagement strategy, because there are so many variety of stakeholders that are involved here, and all stakeholders have different preferences for how we're going to engage with them. Like I said, sometimes we'll be listening more than engaging. Sometimes it'll be more dialogue. Other times it might be more presentation. It all depends on that forum. But when we come back to the board at the retreat, we'll talk about how that engagement has been going over by then it'll be the last 6 months. So open enrollment, the engagement, retiree engagement strategy, those are some key things that are going to be worked on and we'll be bringing back to you at the retreat. Also, by the time it's February, legislative session will be in full swing. There'll be budgets to discuss, bills to discuss, so we know that we'll be having a robust discussion about what is happening there, including what has occurred with the dental decision package that is being crafted based on the conversations that the agency has had publicly with both boards and other stakeholders. So those are just a couple of things that are kind of all in the work right now. And then I want to shift to the last comment for this board season for me, which is we do have likely changes to a few board members. The cycle and appointment process, every year there's the potential for some board members to transition from the board. And I never like to say anybody is gone for sure, because you never really know. And so I did want to acknowledge, in case this is the last meeting, it's possible or likely that both Scott Nicholson, who unfortunately couldn't be here today, and Leanne Kunze this very well could be their last meeting of the board. And just wanted to thank them both for their service to the PEB program over the last 2 or 3 years, depending on their particular timeline, and make sure that we took a moment to appreciate them and the work that they've done with the board and on behalf of members, in case this is their last board meeting. So Sue, I'll turn it over to you for any other comments.
Thank you, Dave. And I would just echo my gratitude. Leanne, I know you're on live with us. You have been a tireless champion. You've been so reasonable and willing, and also so enthusiastic about our work. So thank you from myself, the board, and all the staff here at HCA. And I'm certain we'll be contacting Scott too as he goes through his transition with employment to express our gratitude directly. I sincerely mean this when I thank the full board for their attention to the detail, for their enthusiasm, for their eagerness, their curiosity. I don't think people ever in their wildest dreams thought that healthcare would turn into such a medical industrial complex. If you are wondering what I mean by that, again, I implore you to listen into the Healthcare Cost Transparency Board today from 2 to 4, where there will be all sorts of deep dives into probably the biggest part of healthcare spending, the hospital industry. And, that board will systematically be reviewing things like executive compensation packages, which are published publicly. We are getting so much more information and detail about true costs of care. We just simply are being so outpaced by our other global partners that we have to examine what is going on here. So board members, thank you for being on this path of oversight and responsibility for all our public employees. And Dave and your team, thank you. You do an amazing job guiding us through all this. And we simply have to, in order to be good fiscal stewards and ethical and certainly comprehensive, we have to continue our curiosity and pursuit, and we have a duty. So we look forward to seeing you back in February. And Tom McRobert, you have your hand up. I will call on you.
Yes, I was wondering, is there a Zoom link for this transparency board meeting today?
Yes, there sure is. And Tom, I will have my assistant push it out to the full board. I don't have that right at my fingertips, but I'll have somebody push it out to the full board for anybody that wants to listen in. But it helps people become so much more aware of how these costs layer into premiums and what we all need to be doing to question and push back. We simply can't just receive this notion that things go up and up and up. We have a duty to really probe and examine. All right, Tom, we'll get that pushed out. Connie will work with my assistant to push that information out. See you all in 23. At this time, this meeting is adjourned, and thank you all.